Well, I am very honored to welcome Dr. Bonni Goldstein, who we had actually reached out to invite to join us in Spain and for our ICRS meeting. And unfortunately, she wasn't able to join us. And so we invited her to join us for this monthly meeting. And so Dr. Goldstein is the medical director of Canna Centers, a California-based medical cannabis specialty practice. And after years of working in the pediatric emergency medicine, she developed an interest in the science of cannabis after witnessing its beneficial effects in an ill friend. She's treated thousands of patients with cannabis since 2008, with a focus on children with intractable epilepsy, severe autism, and advanced cancers. Dr. Goldstein is researching cannabis-responsive salivary biomarkers to measure the impact of medical cannabis on children with autism and has documented objective improvements that correlate with clinical findings. And this has led to her new company, Goldstein Wellness, which is focused on helping healthcare practitioners integrate cannabis-based treatments into their practices. So welcome, Bonni. I'm going to stop sharing my screen and you should be able to share yours.
Thank you so much for having me. Bear with me here. Hang on one second. I always struggle with share screen, so give me 1 second. Here we go, share. And can you see that?
Yep.
All right, so we'll start at the beginning rather than in the middle. All right, thank you so much for having me. I appreciate the invitation. I'm so sorry I can't be at Spain. It's at the same time as we have a yearly camping trip that I'm not allowed to miss. So I will be thinking of you in Spain though. You know about me now. So I've been working in this field for almost, 16 years this year. And because of my pediatric background, I kind of became the magnet for all the pediatric patients in California who needed help with severe epilepsy, other refractory conditions, and certainly a lot of pediatric autism patients. Right before COVID, I was approached by Pharmacometabolomics, which is a California-based company looking at salivary biomarkers using pharmacometabolomics to impact the measure, treatment. And so they're also looking at dementia and some other things. But we did our study with autism. It got a little difficult during COVID, but I'm really excited to say that we got some interesting results. I think the group here understands what we're dealing with autism. Of course, this it's epidemic proportions now. I think back when I started as a pediatrician, I think it was 1 in 250 or 1 in 300, and now we're talking about 1 in 36 kids. We know that they have tremendous inflammation. We have limited options for treatment in the United States. There's only 2 FDA-approved medications. They have lots of side effects, and even my counterparts in developmental pediatrics and neurology often say they hate prescribing these medications because of those difficult side effects, especially the weight gain and the risk of hypertension and diabetes, as well as not really seeing great results, especially with the core symptoms, because they don't address the core symptoms. And of course, this leaves us with many challenges for families and also for schools and just a difficult existence. A lot of my families that come to me tell me they don't ever leave their house. They take turns staying up at night to stay up with their child who's not sleeping. They're considering residential placement because of the aggression and the fear, especially in siblings. As we all know, a tremendous burden. And then if you have not read some of the research on medical cannabis for autism, I think this is a really nice review. It is a couple years old, so there's more research now, but it's just a very nice overview of both preclinical and clinical. And so interesting, we have evidence of endocannabinoid system deficiency and dysfunction in these kids with lower levels of anandamide. We also have some observational studies showing really impressive numbers, right? 70 to 93% participants having some improvement. And 2 retrospective reviews also documenting over 60% improvement, including in the core symptoms. And then a number of studies showing that we can get them off some of these more toxic medications or at least decrease the dose, which I definitely see in my practice. And again, I don't want to be here as the cheerleader as it helps every single patient. There is certainly a population, I'd say in my practice, somewhere between, I'd say 20 to 30% of kids. It's just very difficult to find what works for them. Some of them are exquisitely sensitive, like literally one drop of oil and they're, off to the races and more hyper than ever. And then other kids tolerating mega high doses. So it would be nice to have a different approach than what we're doing now, which I'll get into. These are the reports I see with my families for sure: less anxiety, less aggression. And I would say those top three, the less anxiety, less aggression towards others and self, and better sleep, are the top three things that people report as being beneficial in terms of kind of helping the family heal and at least getting through day to day without so much struggle. But parents also report less rigidity in terms of the difficulties they have with kids. Like I have one family that if the mom made a left instead of a right on the way home from school to avoid traffic, it's a 2-hour meltdown. So, these very difficult behaviors. Improve socialization, improve speech, comprehension, better focus. And I would say that repetitive behaviors are plus minus, in my opinion, with what I've seen in my patients. For some kids, it is cannabis can be helpful, and for others, you get these other benefits, but you may not see the help with the repetitive behaviors. And also hoarding is a big one. Some of these kids are into hoarding, and I find that cannabis doesn't always break those patterns. And as I mentioned, trial and error. It is so difficult to assess what's working. It is time consuming. Literally, we try something, and if it doesn't work, I get an email that night, the next night. And it's not so much just, labor intensive for parents and clinicians, but it gets tedious, it gets expensive, and people often give up. So it would be nice to have the answers to these questions. Who might benefit? Should we be giving it to every child with autism? Or maybe there's some kids that are high functioning or don't have as many difficulties that maybe they are not going to benefit. And I've seen that. Can we pre-select cannabinoids and products rather than just kind of starting at point A and working our way through all the available compounds that are out there? And then also, how do we assess these outcomes objectively? And that leads us to the pharmacometabolomics research. And if you're not familiar with pharmacometabolomics, it's the systematic identification and quantification of metabolites in an organism or biologic sample. It's really not that much different than drawing blood and looking at cholesterol levels and then trying to treat those levels, and then even following up and determining, okay, if this medicine helped bring that level down. It really is looking at this metabolome or this makeup of the metabolites in the child. And I'm showing you this graphic just to kind of compare the genotype and phenotype. And remember, with genotype, yeah, we can get the DNA and it's predictive and it can be helpful, but the idea of the metabolome is you can see what's going on in this human being right at this moment when we collect that biofluid. And what this allows us to do is quantify that individual's response to treatment. And so that's what I'm going to show you in our results. This is kind of just the pathway for pharmacometabolomics, is collecting the sample, and you can use really any type of biofluid or tissue. There's sample analysis, different ways to do it. And then you basically assessing the data, filtering, normalizing, scaling that raw data, so then you can actually generate some meaningful data to be able to analyze what is going on in those patients. And I do have some heat maps to show you. We published 3 papers on this one research project, and we've got some pathway maps and heat maps and so on, which I'm more than happy to share. In the interest of time, I just have a little bit limited here. So this was the first paper that we published in December 21. And prior to this, there were some proof of concept studies looking at which of these metabolites actually might be responsive to cannabis, and they're called cannabis responsive biomarkers, or CRES. You'll see that in my slides. And in this particular study, we looked at metabolites that had roles that were particular for autism. So inflammation, bioenergetics, amino acid metabolism, neuronal activity, and also endocannabinoid system metabolites. And so we recruited 15 children with autism that were already under my care, had been at least treated for 1 year, and were on a stable regimen of cannabinoids, which you'll see in the next slide. And so remember, these regimens that they're on are not cookie cutter. They're customized to the child's response. Again, going back into that very labor intensive, change this, back and forth with the parents over a period of time. We collected 2 saliva samples for each child in the autism group. So they had a pre-medical cannabis saliva sample, as you can see on the right, after following these instructions. So no medical cannabis for 8 hours, no food or high sugar drinks, so that the saliva was not, did not have any confounding variables. They rinsed their mouth. The parents did a behavior survey, collected the sample, and then they got their regular dosing of their medical cannabis. And then in the afternoon, or about 90 to 120 minutes later, when the parents had reported, most parents reported between 90 and 120 minutes was when they kind of saw the medicine kick in. And we collected another sample and did another survey. We established a physiologic range of metabolites in a group of 9, from a group of 9 typically developing children who are not on medical cannabis. We ruled out anybody who had any neurologic disorder or condition, and no IEP at school. Basically just typically developing children of similar ages. We collected 1 saliva sample in the morning. Here is the treatment characteristics of the patients. So here's their ID number. We started with 18, but we had some difficulty with 3 of them. So we were at 15 patients again. Ages, and before age 6, it's hard to collect saliva. It's not a swab. You actually have to voluntarily spit into a test tube. And then after 12, we were trying to avoid too much puberty, to be perfectly honest. So although I think we found some interesting findings in this group that's pre-pubertal getting into puberty. If you'll notice, mostly boys. We actually had a little trouble recruiting girl. Dosage per day. So if it says 2, they got 2 doses, and morning and noon. If they got 3 doses a day, they got an evening dose as well. Some kids only took their medical cannabis in the morning. Everybody was on tincture, but edible, we just separated out if the parent mixed the tincture oil with food to get it into the child. So like mixed in peanut butter or yogurt or oatmeal or whatever they took. And then as you can see, the various cannabinoid content, and you can see nobody is on any, none of them are on the same thing. Again, this was really all personalized medicine. And I want to point out that towards the end, you'll see that when we did our machine learning part of this, we only included the first 3 major cannabinoids because we just didn't have enough data on the others, so we left those out. But you see a lot of differences here. Some kids not on CBD at all, and some on really high dose. I've got kids even on higher doses than that. Some on tiny doses or no doses of THC, and some on fairly high doses. Again, I've got kids, that range all over in terms of their dosing. So if you look at the behavioral ratings before medical cannabis, what you can see is that parental rating of symptoms before. So this was the pre. We can see that 11 children have severe symptoms, rated severe, based on 3 different behavioral scales. And so for the first 2, higher number indicates worse impairment or difficulty. And for this last one, higher number actually, or lower number indicated more difficulty. So red means not so great. So not everybody was terrible, right, on the day of. And remember, these kids are just like everybody else. They're allowed to have bad days. And the day we collected may have been a good day or a bad day. 1 child was rated moderate. 2 children were rated as mild. And then here I just want to show you how we established the physiologic range for the metabolites. So this is patient 1 to patient 9 for the typically developing, and this is their average. So that's the average right there. And then what we did was we looked at different standard deviations away from the mean, and we figured out that anything that was plus or minus 4 standard deviations away from the mean was statistically significant. And what you can see here is that what we wanted to see was, where did these metabolites or the metabolome fall for these kids? Was it optimized? Was it in the physiologic range? Was it borderline, or was it symptomatic? So this is just an example. This is not findings. So in our children with autism, what we defined as significant was anything outside this 4 standard deviations, and then optimal would be within this, basically within the 2 standard deviations. But again, that's up to borderline. I hope that makes sense to everybody. Yep. All right, and then the behavioral ratings after cannabis, what you can see here is, let me just move this little window down. After medical cannabis, the parents again did that survey, the 3 scales, and 11 children improved. 2 had mixed response, and 2 exhibited increased difficulties when we collected that peak saliva sample. But if you look at those reporting symptoms, we broke it down in terms of percent improvement. And these numbers, look, they impress me in the population of autism. I know it's a small group, it's 15 kids. And again, goes to show you cannabis is not a cure. It's just helping manage symptoms. No change, not too many things there to look at. But in terms of worsening, you're going to see some patients, again, day to day, maybe asking them to get saliva may have irritated them, and so they had a bad day that day. But what's interesting, and this is what I see definitely in my practice, is restricted repetitive behaviors maybe even got a little worse, although there was some improvement, and the social initiation. It's always a mixed bag with these kids, but I just wanted to point out that what we saw overall was a pretty good response, which is, again, what we see in general. So we detected 484 known metabolites, 65 were identified as autism cannabis responsive, meaning we saw a change in those patients, and that had to be in at least 8 participants. But in all participants, 31 metabolites were detected in terms of common for them, and 21 metabolites of those exhibited statistically significant shifts with medical cannabis. And these are our algorithms, which, I'm sorry if it's not clear, because it might be a little confusing in such a quick manner, but what we did was we counted the number of children with autism who showed an increase or decrease in the metabolite concentration in response to medical cannabis. And then we compared them to the neurotypical children by calculating the mean relative to the typically developing participants. And then we compared using standard deviations, and we calculated basically the movement from pre to peak relative to the typically developing, and we used Z-scores to measure that change. And what we saw, for instance, this is just one example. So N-acetyl aspartate is a highly abundant neurochemical. We were able to measure this. There's evidence that it reflects neuronal density and viability. And what's interesting is in the scientific literature, there's evidence of low levels in patients with autism, but also some evidence of high levels. So again, either too high or too low. And what's interesting about what we found was somewhat the homeostatic nature of cannabinoid medicine, which is, nice to see it in science rather than just a theoretical idea. Each one of the patients is along the bottom. So you see A1, A2, starting with that 6-year-old going up to the older kids. Here's your typically developing, and you can see they're all within this kind of very close range in general. And what you see is the dark blue is the pre, so this is before cannabis, their NAA levels. And then the light blue is their peak. And what you see here is pretty much shifting from, let's say, for instance, A2 shifts down. What you're seeing is towards the physiologic range. And what you really don't see, apart from A12, which almost is very similar, what you see is almost every patient low kind of goes up. The cannabis brings them up to that physiologic range. And notice in the kids that are older, they're very high levels, and all of them kind of came down more towards the range. So really interesting findings in terms of that one homeostatic nature, but also we're not really seeing, and remember, these kids are optimized on their medicine over time and stable, doing well. What we're not seeing is any of these go out of whack, right? We're not seeing them go away from the physiologic mean. And just we took 3 of the older boys. You can see their ages. You can see that's not their real hair color. That was just to differentiate them. And you can see their product use. And this is basically just another way to look. These are all the cannabis responsive biomarkers here. This is how they plot. You see the physiologic range, -2 to +2 standard deviations with the mean down the middle. And just as kind of a quick look, what you see what medical cannabis does for these children. And I think this is, again, it seems always that cannabis is held to this extra standard that it has to be perfect. It doesn't need to be perfect, but what we're seeing is that what the parents are reporting is correlating with the cannabis responsive biomarkers that reflect these underlying chemical pathways, again, going back to inflammation, aggression, endocannabinoid system functioning. Now, in our third paper, our second paper was just on the cannabis responsive biomarkers that fell into the lipid category. So I'm not sharing that right now just because it's not enough time. But this, we took our data to evaluate through machine learning. So this was really eye-opening for me. And happily, I have my son's a math major at school and explained what machine learning was to me because I didn't know. So that was worth the college tuition right there. And then here we have lots of data. So we have 3 categories of children. So the typically developing children, we have the children with autism before they take their cannabis and then after they take their cannabis. We have 484 known metabolites with 65 actually identified as responsive to cannabis. And then we have cannabinoids in various combinations that we looked at. And again, I told you we were leaving out the minor cannabinoids. We didn't have enough data. And for machine learning, everything has to be turned into a numerical, has to be scaled numerically. And so what you can see here, the participants across the bottom, and then we gave them a numerical scale based on our dosing. So we broke up dosing into different dosing levels, and then also the response. And this is what was fed into the machine learning database. And here's just some of the interesting findings. So let me just go through it. I have to move some things on my window here just because I'm covering up. For some reason, this won't move. So I think it's THC. Is that right on the first one? So THC was associated with response of 11 different biomarkers. So you can see those 11 different biomarkers here. This is what THC appeared to, through, again, results from the machine learning dialed in on what THC is actually impacting in these children. So there were some lipids that were impacted, some chemicals that basically are working within the brain, and also some steroids in yellow. And so THC was found to have these 11 biomarkers that it interacted with. And then we have CBD associated with 7 potential cannabis responsive biomarkers. And interestingly, they were mostly lipids, but no endocannabinoids. And that kind of makes sense because CBD appears to work mostly through non-endocannabinoid system pathways, not fully, but many of the targets are outside the classic endocannabinoid system. And notice what's interesting, well, I'll get to that in a second. CBG was associated with 15 potential biomarkers, which I thought was really interesting. And then what's super interesting is there's no overlap between THC and CBD. And that goes right back to what you were just saying about CBD is not going to take care of everything that needs to be taken care of when you are dealing with a patient with especially difficult or difficult to treat or refractory conditions. And if you have a problem with one of your biochemical pathways in this realm, this is not going to necessarily help you. And that is why THC plays such an important part. 3 of the CBG biomarkers overlap with THC and 1 overlapped with CBG. And what's interesting is there's a couple of articles out there, and now ours adds to this, is the idea that CBG resides pharmacologically between THC and CBD. And I've kind of been saying that, and now there's a 2021 report by Nakhnani et al. That reports this. And then I just saw another report the other day that kind of quoted this CBG kind of lives in between, right? It has the similar targets, but even some extra targets compared to CBD, but without the impairment of THC, and you don't need the high doses of CBD. I mean, it's very interesting compound. Now, again, we didn't see any evidence of negative impact of cannabis, but this may be, again, because this was a selected group of patients who are already known to be good responders. And then we did find this last compound, lyso-PE 18-1. It was only present in the children with autism. It was not present in any of the typically developing children. And we surmise that maybe this is a biomarker that could be used to identify children with autism. I think anandamide levels has been put out there floating. You know, if they're low, we know that they're low in from a couple studies. So maybe anandamide levels might help diagnose, but this particular one I think might be even more helpful. And then just last two slides. So application of cannabis responsive biomarkers. So this is what we can do with this technology is predict, will a patient benefit, get a baseline and look at that. And I'm going to show you that in a second. And then what can we quantify their response objectively? Can we suggest dosing and cannabinoid profile at the initiation based on what the data that we have from other patients with similar biomarker maps? Can we monitor patients, serial measurements to assess status and also obviously diagnostic ability? And then here's one of those maps that I'm going to show you. So what you can see, first look at the bottom. Optimal is that light blue. Physiologic is in the darker blue. So that's getting to that -2 +2 standard deviations. And then symptomatic is what we're calling in that red zone. And so here you see a patient, not very happy patient that has a fair amount of red, but also some dark blue. So not totally terrible. And what the idea here is that if we have someone with this map, heat map in our database, and somebody comes along who has, here's the patient in the database, and here's the patient who's new. If we know that we can, this patient's profile, their cannabinoid profile, their product profile leads to this kind of benefit, can we use that as a starting point? So that's the whole idea, is to help minimize that trial and error, that expense, the stress on the family, the finding of products. As you all know, it's rife with issues. We still do it, but wouldn't it be nice to have some more information before we move on? And so that's my research in a nutshell.
Amazing, amazing, amazing work. And thank you so much for sharing it. I think you are speaking very much to the choir that would love to do, to have more evidence to guide therapy. And our whole topic for Spain is around precision cannabinoids, right? This whole idea that, you know, not all the kids are responding and that there's so many complex molecules in these compounds, and we're not sure if the response is because there's some THC or some CBG or something else in there. And so I'm going to open the floor. There's some